Welcome back. We are moving on to S-142, which is the International Trained Physician. And Jen has some new language for us that remember we talked about on Friday. And she has incorporated our suggestions and the suggestions of reading H. Spoiler alert, this is not going to be the final version of the book. So don't get all.
Good morning, Jen Farby from the Office of Legislative Counsel. So yes, I'm going to put language up. I just sent it to Tasha, so it may take a couple minutes before you can see it on your computer. But this is reflecting the Health Department proposal from Friday, and there have been some additional conversations between the department and some of the stakeholders since then, so they will be coming up after me with a new proposal, but it builds on this one. So let me put this up on the screen and we will walk through it. So just a reminder, the context of the bill we're talking about is this pathway to licensure for internationally trained physicians. I did take their suggestion to use internationally trained physicians and not medical graduates because of the issue that we talked about last week, where there is already a process for internationally trained medical graduates to do a residency program in the US or Canada and then become licensed in fully licensed here. So this is the pathway to licensure for internationally trained physicians. And so this would be a strike all. So we would get rid of sections 1 through 3 in the bill that came over from the House, which is sort of setting up the process. And then it would go directly to what was section 4, something similar to what was section 4. Okay.
Somebody muted, somebody not muted.
Thank you.
Do we have that language?
I think it is somewhere.
It's our posted.
Yes, it's in the ether. Yes, it is. It is in the ether. So it should be up soon. And so one of the things I did, the proposal that I think was brought to you on Friday used an order of kind of using the order that was in the bill as introduced, amending the statute, and then having the report. I tried to put this in more of a time, the order of how things would occur in time. So first thing would be this. So this would have on or before January 15th of 2027, the Department of Health, in collaboration with the Board of Medical Practice, providing to this committee, the government operations committees, and the Senate committees a report detailing a pathway to licensure for internationally trained physicians that would include a summary of other states' processes for licensing internationally trained physicians to practice medicine, and, if available, data on the outcomes. A description of the external resources, so most of this is the same language except as highlighted. Description of external resources needed and the availability of those resources. A proposal for licensing internationally trained physicians to practice medicine in Vermont, including potential qualifications and supervision requirements for licensure. I added something along the lines of proposed requirements for recency of practice to get at that how many years of the last however many years. And then a summary of additional resources for authority needed, and a plan and timeline, and anything else that the department deems to be relevant. In preparing the report, the department would still use, this is mostly the same language, consult with other states that have implemented licensing programs, changing this from the Vermont chapter of the NAACP, which I understand is not how it's organized, to be specifically the Windham County branch of the NAACP that has been actively involved in this work. Third-party credentialing services, the Vermont Medical Society, Association of Hospitals and Health Systems, other advocates, researchers, and other entities whose expertise is relevant. Then we would have a new, and this is based on their rulemaking proposal, new section on rulemaking entitled Pathway to Licensure for Internationally Trained Physicians. Rulemaking. This would direct the board to establish a pathway to licensure for internationally trained physicians by rule in accordance with the Administrative Procedures Act. The rules would include the qualifications necessary for the board to provide a provisional license to an internationally trained physician, I had put language in here saying the scope of practice authorized for the holder of a provisional license. I think the department has a different suggestion because they're not proposing to limit the scope of practice. So that's sort of placeholder language. And the additional qualifications necessary for an internationally trained physician to obtain a full license to practice in this state following successful completion of the provisional licensure period. And then in section 3, which was section 1 in the bill, a bill as it came over from the Senate, would be on internationally trained physicians, and I've just struck medical graduates. And this allows the board to issue a license to an internationally trained physician who has successfully completed the pathway to licensure. And then the language would be modified to say established by the board by rule pursuant to section 1393. And then updated the effective date. So the report and this section would then the effective date section would take effect on passage. The rulemaking language would take effect on July 1st, 2027. And the authority for the board to issue a license to someone who has completed the pathway would take effect on July 1st, 2028. So that's where we were as of last Friday. And then if you want to hear next from the department, or if you want to.
Any questions for Jen? Go ahead.
just to orient myself. So what you have here, this new 1.1 replaces as passed by Senate, the whole thing.
Yes.
That's all.
And then, yes, and I think that's what the proposal you're going to hear from the Department of Health also would, updates the language we just went through still as a strike all to what came over from the Senate.
I just want to say that this now goes away and I can look at 3 pages.
Yes. Although it will become more pages.
Expand, but
It will expand as of this moment.
Okay.
Yes, that is the proposal, is instead of what came over from the Senate, having the report from the department and coming back in January with rulemaking beginning next July and the pathway being available starting July of 2028.
We have like 3/4 of page 3 open, so maybe it can still remain.
Oh, yeah, no, it's not going to stay 3 pages. I mean, it's, it's because it is satisfying the parties,
Okay.
various parties. You may be perfectly happy.
I did notice, so we get rid of medical, which again, I don't have an issue with. But that program is ending April 30th. And it's
No,
with the
program?
ECFMG it is. At least that's what I read online. Is that not true?
I'm not aware of any.
And that they were gonna replace it in the third quarter or second quarter of 26 and possibly 27.
I don't, so there,
I remember Dr. Greenberg talking about that. And I don't think it was because the selection has already been made because we're past match day. It like they ended it, but
we're just
then
transitioning.
they're transitioning. So next match day, it will have a different criteria.
Yeah, they said that it is gonna be replaced or
Yes.
with a,
Yeah. So the fact that it
Some
ended,
modification.
it doesn't really matter that it ended right now because they already went through the process and match day already happened and there won't be another match day until next year. And there'll be a new thing in place next year.
all right,
But that's not relevant to these people.
So unless there's something statutory that links
No.
us to an existing
Right.
sort of scheme with the, I'm not going to remember the,
I think
Acronym.
I think that was one of those things where it was like too much information that like doesn't really pertain to the bill and
we'll make sure you've got the health department folks here. So they're on notice if there is anything that needs to be done with the statutes to ensure that we're still able to provide the licensure to people who finish or who complete the residency in the US or Canada under our existing statutes. We can update that. But it sounds like that may be an operational issue at a national entity that does not affect our process.
in fact to file away for trivia if it ever comes. Okay. Thanks, Jen.
Yes.
And well, we don't have Lauren on our schedule. However, Lauren's here and Lauren's got some proposed language changes. So if you want to come on up.
Thank you. My name is Lauren Lehman and General Counsel for the Department of Health. And I want, gonna take a moment here and share, hopefully if I can figure it out, please bear with me. Some language. So yesterday I spoke with, make sure I get the right version here. Diana Wall, excuse me, and the Windsor County chapter of the NAACP. Wyndham, sorry, Wyndham. I do mix the two.
Let me get my county right.
Thank you, because I think there's an edit here. And then I also spoke in Mike Zimmer from West, from the Washington, the World Education Services. There we go. And they're both very gracious with their time. I think we have some good, we had some good compromises. I don't want to speak on their behalf. They did indicate to me last night that they were supportive, you know, of this language that I'm showing you now. And we did work together on this. So I will, you know, let them speak for themselves. I don't want to speak on their behalf, but we did collaborate extensively on this yesterday and came to an agreement yesterday afternoon. So the changes, and Jen hasn't had a chance to work her magic on this draft yet, so there are some technical details that I think she wants to hear from all of you before we move forward. So the study remains very similar to what it was before, and we will provide that again as somewhat of a check for this committee and the legislature to look at next January to make sure that the department and the board are moving in the direction that you see as appropriate. And if you don't think we're going to be adopting rules that are appropriate and meet the standards or create artificial barriers in some way, you may, you know, you could take legislative action at that time. So there's still a check on the Department of Health to ensure that we keep our commitments. And then the qualifications for licensure is, we fleshed it out a little bit, just to make the language consistent with other licensing language. So the board may issue a provisional license to an internationally trained physician who has successfully fulfilled the requirements for provisional licensure established by rule, and we'll go through 1393 in a moment. Oh, did I skip 1393? I did. I'm sorry.
No, you're 1391.
But I skipped section 2 here. I think because Jen put it again in the order it would happen. So 1393, the rulemaking will happen before 1391. So 1393 is where we talked quite a bit about what type of rule the board shall adopt. So the board will adopt rules necessary to carry out the requirements in what we'll talk about later, that issuance of the license, the 2 licenses, the provisional and the actual. It's subject to, or the board would adopt those rules in accordance with not only the Vermont Administrative Procedures Act, which is 3 VSA Chapter 25, but we've put a reminder in here that the commissioner under this 1351E has the authority to adopt, amend, and repeal any of the board's rules. So that's a reassurance that it's not just the board that's going to be doing this work, and I hope they feel reassured by that as well. It's the department who will be doing this work, overseeing this work, facilitating the conversation, doing the research, and assisting with, you know, how we learn from other states and how we build this program in a way that acknowledges what their experience is and the community's experiences, and the board's concerns. I think their concerns are valid, but we can also learn from how other states have done that to address their concerns. So that's what's reflected here. We also use some language from elsewhere in licensing statute to say that the board shall, the rules shall be the least restrictive form of regulation necessary to protect the public interest. It's very common in professional licensure in Vermont. We're not building the perfect licensee. We're building the minimally competent and safe licensee. That is our job. We're not creating the perfect, the pinnacle, but minimum necessary. the qualifications necessary, and then we did call out some things specifically that the board would do, included but not limited to qualifications, for the provisional license, standards for the assessment and evaluation, and, any other qualifications needed for that full licensure, after successful completion of the provisional license period. 1391 then gives the board authority to issue those medical licenses. And again, we very clearly laid out, and this was, Mike mentioned that in other states, there have been issues about ensuring that the board has authority to issue both the provisional license and the full license. So we wanted to make sure we were really explicit here. And this is one of those areas where we're learning from other states. So we called out, we have the board has the authority to issue a provisional license and a full license. And then this is an area that that World Education Services and the NAACP really wanted to make sure was in this bill, and we're supportive of that, which is defining what a participating healthcare facility is. And this is from the Senate passed version of S-142. We did amend the definition of participating healthcare authority facility to remove the requirement that the board approve the facility. I'm concerned about that legally because of it kind of creates a sub-licensing of the healthcare facility and the, legal rights attached to that. And I think there's some procedural concerns around that as well. So everybody was comfortable removing that. But then the rest of the language mirrors what was in the Senate passed version for participating healthcare facilities. We also removed the definition of internationally trained physician. We'll be defining that through license, first of all, and we can work on a definition in the rules. I was concerned that it required that the person be a doctor of medicine or have a doctor of medicine. I've heard from other providers that have worked in global international and global health that some countries don't have a doctorate, they go to a master's level. And so just by defining it as a doctor of medicine, we're limiting that pool. Wanted to be flexible there. So we removed that definition here for something to reflect on in the rulemaking. And then again, we had just the language from the Senate passed version, and we updated the effective dates to reflect that the participating health care facility definitions would take effect. So.
Thank you for working with
Pleasure.
others on this. Anyone have any questions for Lauren? And I'm glad JFO just walked it. I just want to reiterate. There's no fiscal note on this. There's no appropriation required on this. There's no, we need money to do the work.
Not yet.
Not yet. Yes, you will come back to us if you need and with
It's
further,
based on new language,
yeah.
because the old language.
The new language, the one that we will not need to, we will come back with an assessment of fiscal resources needed in the January report. Be in touch.
I like to get that out of the way, right? And we can clarify it. Go ahead, Daisy.
I noticed that just real quickly before you took the language down, there was a requirement that the facility, the hiring facility had malpractice insurance. We heard from one witness, something about the provider or the licensee having malpractice insurance. How did you determine, who to require to have that?
That is in the S1, that is in the language from, of course, there it is. That is in the language from the Senate. So I can't really, I don't feel comfortable speaking about it. Maybe Boz or VMS will have more information on how hospitals and facilities typically carry their medical malpractice insurance for their employees, but
It's fine. I thought you had made a change to it. It would be a question for the person that talked about the licensee having it then.
got it.
If I'm not mistaken, typically malpractice insurance covers more the employees within the facility, not necessarily the actual individual in every case. And maybe we can get more info on that, but go ahead if you want to.
Just Barr with the Medical Society, my understanding is it's typically both, that the facility would have its own insurance policy, and the individual clinicians do need individual malpractice insurance that names them. The employer may purchase that and provide it to all of their employees, but it has to be for the individual and name them, because in suits often both are named, both the facility may be sued and the individual provider. So the individual provider would need malpractice insurance, whether that's provided by the employer, which is the typical case, the employee, or provided directly by them. It could go either way. I think typically if it's an employee provider, the employer in some way does provide that, but it is naming that individual, not the facility as a whole.
And the language here requires the healthcare facility to have the policy, and that the policy that the healthcare facility has cover the individual.
So that would typically address, I think that would address this most common situation.
Any other questions for Lauren at all? Okay. So we're gonna get this new language to Jen, and
That's what. Is that the same?
is everybody good with the new language? And would like Jen to work on that.
Yes.
Okay, great. So we will incorporate that. And I would like to, it is my understanding that we are not gonna have any time in committee tomorrow. Is that still?
How long the debate was on for?
Yes. So we can let's wait to see how floor goes. If we have spare time tomorrow. Is there anybody else we need to talk to on this bill, do you feel?
I don't think so.
Anyone feel like they need anyone else to talk to? Any information? Burning questions or other perspectives? Dave, you're looking.
Well,
I don't know you very well yet, but I think I'm reading like.
my concern is at the federal level, that we have no authority over. The visa applications right now are major issues.
Mhm.
So I think that that's going to impact the success rate of this bill. So that's the frustrating part that you sense right there.
Was it as part of rulemaking? There was something around I mean, you have to have a work
Be
status.
eligible, yeah.
You'd have to be eligible for like a work type visa.
Yes, but right now there are 39 countries that are ineligible for visas.
And this is the bill is not designed for people who are outside of the US. It's designed for people who are already here.
Already here, so we don't attract. Oh, okay.
Right. It's
Then
for
I,
people who are already here.
well, that's better. Except that the visas that are already here, they're taking a look at those as well, of whether they're not going to renew them. But I am in support of the bill. I just,
And I will say, Dave, I am willing to have lots and lots of people in here on lots of things, but I really don't want to call the federal government and ask them if they want to come in and give us status
Really?
on immigration.
I am surprised, Madam Chair, but I understand.
Just a testimony, I don't really want to
Yep.
open up. Lauren, did you have something that you wanted to?
Lauren Lehman, Department of Health, General Counsel, whoever. There's several different variations on the visa requirement among the 20, yes, I heard yesterday, 25 states that have adopted this legislation so far. There's several variations. And so that would be something that we would study in the report and bring back. And if there's a statutory fix needed, Maybe that's something that the legislature, there might be other things that need to be in statute rather than rule, that would be part of our report back in January.
Good, thank you.
And who knows what it's gonna be in January? The immigration status.
Tomorrow.
Okay, anybody else have anything that they feel like they need further info on? Okay, so if we do not have any time tomorrow, we will plan for this to get the final version next Tuesday. And final markup and vote on that. If for some reason we happen to have spare time tomorrow, I'd kind of like to get it out by tomorrow. So we could probably make time for that. Let's make a game time decision based on what we have for floor tomorrow. Would anyone like to come in at 9 AM? Oh, wait,
Floor's at 9:30.
yes, I was thinking 30 minutes. Honestly, I actually can't. I can't be here tomorrow morning before 9:30. So nice suggestion, Tasha, but no thank you.
I think she is. It's progress over there. Let's go.
Okay, so let's move on. S-189.
Like literally.
S-189 is the bill on notice of reducing or eliminating hospital services. So Jen did another walkthrough, second walkthrough of this bill last week. Everybody wants to like pull it up. So as I mentioned the other day that I wanted people to be thinking about, here are the 5 paths that I see with this bill.
5 of them. Uh-oh.
5. Number one, we could do nothing. We could leave it on the wall. And what that would do is that would have the effect essentially of what we currently have in statute right now, which Jen walked us through, which is what we did last year. That process would remain in statute and that would continue. So that would be the effect of doing nothing and leaving it on the wall. Please correct me if I'm wrong, Jen. That's
That's in this bill, I think, right?
and that's all the language in this bill that has the strike in it. Let me find the bill, the flip flopping the bill so much.
Want me to come up with the-
Sure, Jen. Great, sure. So basically, it's page 4, end of page 3, and and most of page 4, everything that's struck through, that would not be struck through, and that would be current procedure. Which is what we have right now. And I know we've talked about, we've talked a lot about Rutland Regional last year. When they came to the board with their notice of service reduction, to eliminate, is it 4 beds or 6 beds? I'm forgetting, I think it was 4 pediatric inpatient beds. And that the board, I think they have testified, felt like they were in a real bind of, well, we don't have information to make the decision on whether it is appropriate for them to close because there's no statewide strategic plan and hospital transformation hasn't happened. So we're trying to make this decision blind. AHS felt like they hadn't finished anything, so they weren't willing to make recommendations. It became a very public process. Probably the only outlet that the public had was to the board, which was if you want to watch 4 hours of public comment, go back and watch that board meeting. And that process would remain in place if we do nothing. Okay, option number 1, do nothing. Option number 2, keep this bill exactly as is, as passed by the Senate. It lays out public process. Oh, I should say, keep the bill as is from the Senate, except to change like the timing, because remember, I mean, everybody agrees that the timing that came out of the Senate really didn't really align very well. So we would maybe tweak timing. When I talk about the timing, you know, like the hospital has to post on this day, and then they have to notify the board on this day, and then within 30 days, and then so a lot of days that didn't quite align. So we would fix that. However, other than that, we would leave it as is. What that would do is it would create a public process that hospitals would have to go through, get public feedback, and then the Agency of Human Services essentially would have to do kind of an analysis and then make some sort of non-binding recommendation. Sorry, I keep harping on this, but it cracks me up because a recommendation is by definition not binding, but sure, if people want to hammer home that you don't have to listen to us, you can add that extra word in there. They would make a recommendation to the board, and the board would say, okay, whatever. And then it would ultimately be up to the hospital to decide what they're going to close and what they're not. And the board could, in their budget review, they would be able to change hospital budget orders as far as to account.
It could be mid-year.
Yeah, it would be mid-year. Okay, so that's option 2. The other options are we could just keep the public process, remove the back and forth between AHS and the board, can maintain the board's ability to adjust their budget based upon the elimination. Okay, so that's option number 3. Option number 4. We could make AHS make a binding recommendation to the board and make a decision. Option number 5.
Okay, still taking notes. Make AHS binding, you're saying binding recommendation to the board.
They make the determination
Binding
They
determination,
say-
not yeah.
whether or not it stays or it goes.
Which is basically, I think, Jen Carver, legislative counsel, the bill as introduced would prohibit a hospital from reducing or eliminating a service without approval from the
Yes.
Secretary of Human Services.
Yes. It's the legal language will be better. I'm just like. That's all.
Right, but I just wanted, like, because it's
That would
not
be the
just a recommendation, it is an approval, it is an affirmative approval requirement.
And then number 5, we could change it and we can make the Green Mountain Care Board make the decision. Whether or not to approve or deny. Those are the 5 options we have before us. So,
I like 2. They have to just announce it.
We could keep a public process in 5 though.
Oh, I hate 5.
Yeah.
when I'm talking about 4 and 5, the public process would stay.
That's important piece, yeah.
Yeah.
Public process stays in all of those options except for number 1, which is do nothing.
Just question about the, letting the public know. These hospitals are gonna know way ahead of time. They're not just gonna say, oh, let's go have a meeting with the public, we might be closing. Their minds are pretty well made up, I would think. Okay, so if you go to the public option, who is gonna say close down a service in their local hospital?
Well, it would have to go through a public process where the
I know,
public
so-
would be able to have a say.
They would have a say.
They don't have a say. They can stamp their feet.
They have an opinion.
They can stamp they have an opinion, but they don't have any,
So what the hospital can do, they're gonna do it anyway.
They're made aware.
So if not, if you take the public comments at heart, then you're gonna have to get the Green Mountain Care Board involved because they might have to redo their budget to stay open that service.
Well, that's what that whole part in there about Green Mountain Care Board adjusting their budget based upon.
And how much power does the public have other than opinion?
Power to the peaceful.
no more power than that. In my experience.
No, that's
in my
right.
Little town, I agree with you.
I think AHS, I think number 4, right? It's number 4. I think AHS should have to approve it because we need someone to lead hospital transformation in this state. And we need the people doing that and enforcing Act 57 and seeing that it is followed through. We need those people to be the ones who have the most intimate knowledge about where we're coming from and where we're going, and that's AHS. And someone has to be the one to make the hard decisions. And I think the hospitals will be the ones that hold the data that that can inform that decision. But I think if we don't have someone accountable, someone who's informed and accountable for making a decision, why would we ever close a service, right? That's such a hard thing. The public's going to show up and say, don't take away our services. It just feels like we have to stand behind our goal here with 167, as hard as it is. And I think it's AHS that has to do it. I get it that Green Mountain Care Board is responsible for budgets, but this isn't a budget decision. This is about community services.
Leslie and then Dave.
So I just need a reminder of who's in charge of the state plan ultimately.
AHS.
So I would.
Strategic plan, statewide healthcare delivery.
Yeah, so that's what I'm thinking, that if they're in charge of that plan, then I would think that that's, who has that view? How does it fit in with the transformation of like a closure and the transfer? Is that where it comes from, the plan then? And we do our transformation and we want to do a closure. How does it all fit together?
Oh. Got a lot of plans going on.
That's what I'm There's a lot going.
It seemed to me that AHS is in charge of most of them.
That's what I'm wondering. So I could see how 4 would have appeal, but I like the idea of including the Green Mountain Care Board too.
My concern is that we give the authority to AHS or Green Mountain Care Board. And they tell a hospital, you can't close that service. Now, who's going to fund the money that they are losing because they can't close their pediatrics and maternity?
Well, that I think is where the Green Mountain Care Board comes in to be able to adjust their budget to either allow them to get rid of it or to keep it.
Well, if AHS says you can't close that service,
Mhm.
they're losing, $1 million a year. Somehow that funding is going to have to be made, right?
Mhm. And Green Mountain Care Board would have the ability to say, we're gonna, I don't know, increase their rates, or that they can collect more revenue to make up for that $1 million loss, or any number of things.
So ultimately, healthcare will cost more because we have to fund this losing service?
Possibly.
Okay,
Or less because we agreed to cut it.
You know, I mean, you make a great point though, because I keep waffling back and forth in my own mind on this. Yeah.
Isn't that what's happening now at Rutland? Or am I wrong?
Yeah. So, you know, think about Rutland. Perfect example. They're losing money. I mean, let's be honest, they've got 4 inpatient beds and their patient census in those beds is on average less than 1 person per day. I think they have 142 days total of that last year. There was nobody there. They have to staff 4 beds
24/7.
24/7 when nobody's even there. Absolutely. We are paying for that. However, you then have to ask the question, if that bed's not there, where are they going to go? And they're going to go somewhere else. And is that somewhere else more expensive? Copley, I'll use Copley's birthing center. Copley closed their birthing center. An incredibly hard decision. Talk about the public backlash. They literally were getting, their board members were being threatened. It was an awful, awful process. Ultimately, they made the decision because they could not continue to keep that open with the number of births that they were having. However, they were losing money on that. But by closing that, you've taken all those births up in Stowe, Morrisville, Lamoille County, and you've now moved them to, in a lot of cases, UVM. And I'm not picking on UVM here, but I think that the average inpatient labor and delivery was about 10,000 something at Copley, and that is now 30,000 at UVM. So it's like costing the system more as a whole, which is driving up costs. And that's kind of where I'm like, AHS, you're like leading all of this. And it's sort of up to them, it feels like, to make the determination of not necessarily what's best for Copley, what's not necessarily best for Rutland, and the cost of care for those individual hospitals, but rather, how does it affect the cost of care for the entire state of Vermont as a whole? Does that make sense?
It makes sense, but if a hospital is losing money in the birthing center, then they're losing in their imaging center and then their MRI center, they close, what do you do in the healthcare then?
Well, they closed the birthing center.
Well,
This is
they
not-
did, but
Val has had a question. Or Val wanted to talk.
I'm just curious why it can't be just simply common sense to me. Why can't it just be a collaborative effort and let the hospital be accountable and make their own decision? Why can't we do that?
that's number 2.
Right.
Number 2. And frankly, number 3. And sort of number 1.
If we do that, my concern is that we're thinking locally, we're not thinking globally about our entire system of care. And part of this plan is to think about regionalization of services. To save everyone
Rutland
money.
is begging for a pathway to do that.
Yeah.
They know their strengths and they know what they need to eliminate, to become stronger. And I just support that. I just feel they really know best. And I appreciate and respect the steps that need to be taken that are laid out in the bill, and I just trust them.
Alan, did you wanna?
I just like, I think we have an agency, AHS. That's their job. They gotta make the tough decisions. They gotta collaborate with the hospitals, the Green Mountain Care Board, everybody else involved.
So that's four.
I think it's four.
Wow.
You see why I laid out all these options?
That's all.
If anyone thinks I have any.
Experts in the room.
Sitting here right now, what would you say to them?
Well, it depends what their question is.
Well, we know what Rutland wants to do. But if you don't give them the ability to make the final decision, they're not going anywhere. They're going to keep losing money. So where's the common sense behind that?
I would think that the Agency of Human Resources would work with them to have a system that's going to work for them. If it means closing a few services to keep them above water, those are big decisions, but I don't know. We can do that here. I know we're looking at the whole picture here, but we don't want any hospital closing. I think eventually they're going to. The other thing is with the transformation and AHS is involved, they know what they've been getting all these grants for. Maybe they have some inside information that would help this.
Leslie.
So when I think about it, I kind of think about it from 3 points of view. There's quality, which, I think if people in Rutland were a little worried about because there just wasn't enough, of doing the job to keep skills up. So I think that's an issue. I think there's access, which I think the community was hugely worried about. And that's what Alyssa was talking about. And then there's cost. And I worry that the conversation is being driven by cost. I think we need to think that part of it, yes, but we need to go beyond that. When Springfield Hospital, I'm going to harp again, went bankrupt, the state gave $10 million to keep it open because the community sort of needed it and wanted it. I think that we need to look at the statewide plan. We need to look at state access to all kinds of services. And I think if we can get too local, and that's what I worry about. And if we get too local, only based on cost, we're not doing our community, we're not helping our communities have access and quality. So, Rutland, as the example we're using, they backed off because they were responsive to their community. And that was, you're giving me the face, so I'm not sure what that means.
I'm not sure that that's actually why they backed up.
Well, I can't say, I'm not in that room, but all I know is they decided not to close the service, let's say that. Backed off, meaning they decided not to close the service because they were responsive to their community, and I really appreciate that. Once again, in Bellows Falls, our community made an uproar, but there was no one responsive to us. So I think the Green Mountain Care Board can see the whole picture. I think AHS can see the whole picture, and that we need to look at that with regard to our population.
I'll just say, personally, because I followed the whole Rutland thing. They had plans in place for where those kiddos were. Most of those children, if acuity was high enough, they were being transferred anyways. They had transfer agreements with other hospitals. They had alternative placement within the hospital. You can be on an outpatient basis in a hospital for 24 hours. And they had that still in place. They just didn't have a dedicated pediatric. If I was making the decision, I would have. By the way, option number 6 is not let Alyssa decide.
Not letting her.
But I will tell you.
Okay with that.
But I will tell you, from the board's perspective, the board didn't have any.
Which board?
Guidance, the board, the Green Mountain Care Board.
Not the hospital board,
The board
okay.
did not have any guidance whatsoever on whether or not this is a fundamentally important service to that community and how it fits in with statewide plan. And I'm telling you, if you want to hear gut wrenching, 4 hours of Rutland families, pediatricians,
We got letters from them too.
nurses sat there telling about, you know, how when their child needed that care in that community, they were there. And the Green Mountain Care Board had to listen to all of that and then try to make a decision on it without the benefit of like knowing and figuring out how it fit in with the whole. So, I mean, I have a great deal of compassion for all sides. And ultimately, they withdrew their plan. Chief,
Yeah.
and then Alan.
Right now, there is no
There's what? What did you
no
say?
real plan of the whole of how services are integrated.
It's coming.
Yes, I know it is coming, absolutely.
And we did get an update
Yep.
yesterday on
Right.
hospital transformation.
I
mean,
agree.
We do keep talking in this bill, because it's actually named in this bill.
Yep.
Is the statewide strategic plan. And that's a couple of years off, but we have to remember that they've been working for several years on hospital transformation.
Yep. So I absolutely agree that, you know, I think the plan is needed. Why couldn't the hospital decide they're gonna close the service? And then AHS or Green Mountain Care Board come in and say, we understand your concerns, you're losing money on it. However, that is a critical service for this area. So this is what we're gonna do to help you keep that service because it's so important. Or say,
That's for,
That's for.
it is for,
I think.
sort of. But we need to make sure that that is either funded or that it has to fit into the overall plan.
I agree with you.
So my concern is that we're gonna tell a operating business, you have to keep selling widgets because,
can I ask you?
They have to be the first to propose it.
Can I ask Jen a question? May I ask Jen a question here real quick?
Sorry.
Because I'm realizing as you're saying this, that the bill came over from the Senate, really just says that the board can make adjustments only for the elimination of, or reduction or elimination. It doesn't have anything that the board can make adjustments for the retention. Is
Because
there?
the focus of the bill is on the if the hospital chooses to go ahead, then they notify the parties. And so the Green Mountain Care Board is reacting to the closure.
Yeah. So is there some language that we could maybe have that, you know, if it is determined that it must remain open, that somebody has the authority to adjust budgets, something or other to allow them to keep that open? Is that what you're getting at?
yeah,
Or does the Green Mountain Care Board already have that authority
They do.
without it being
Sometimes we have to spell it.
Yeah.
I had Leslie and then
I just wanted to comment, Dave, that
Yeah.
hospitals I mean, we like to think of them as a business, but they're not. Because people aren't widgets.
Yeah.
People aren't widgets. That's all. I mean. Or widgets. I mean, yes, we want to think about it that way because, and they're nonprofits and all that stuff, but I think they have a mission. Well, all nonprofits have missions, but they're not involved in, most businesses are not involved in statewide. You know, planning, it's big, the hospitals are bigger and beyond, I think, a typical business.
yes.
That's all I-
And
that's
I
all.
didn't mean to minimize, you know, how important they are or the impact of the whole. My point was they get paid for a service, for a fee. And we have to figure out whether they feel they can no longer provide that service because they're losing money on it.
But that's within a broken system. I mean, in my opinion, totally. They're not selling shoes and they're not in a typical capitalist dynamic.
Can I actually push back on you?
Of course.
Hospitals absolutely are a business, absolutely a business. They are not free. They provide services, they have to be paid for those services. I don't know who said it. I know I hear it all the time. No margin, no mission.
Yes.
You cannot, they do not operate simply just
For the goodness of their heart.
for out of the goodness of their heart.
I totally get
They
that.
have to be able to financially
Sustain.
sustain so that they can actually perform their mission.
But there's no business that we're gonna give $10 million to keep them open. Their role in the community is beyond business, is all I'm saying.
And Rutland has already tried the adjusting part. Like, that word, like, they've tried that. And you bring up out of the kindness of their heart. That's pretty much what they're doing right now. Nobody's had raises. There are no bonuses for years
At Rutland?
at Rutland.
Mhm.
I don't feel there's any room for adjustment, and I could be wrong.
But then it's a
I
broken
have
system.
Alan, and then I got Daisy, and then I got.
I won't put everybody on
Alan
the
and Karen, I'm
spot.
sorry.
But I'd like to hear from the healthcare advocate on this opinion.
I don't want to take any testimony right now. This is just us. We're gonna take more time. Oh, believe me, we're gonna take more testimony. I was just trying to get a sense by today about kind of like maybe the thoughts on where the committee was having, or wanted to go. Because frankly, I was hoping you all would have an idea of where to go, and I'm finding that you all are just like me. I've got Karen and then Wendy.
So where I keep getting stopped in thinking about this is the statewide healthcare delivery strategic plan once established. So I feel like there's a lot of active work going on at many different levels, a lot of AHS, keeping tabs on it. And so understanding where things fit in systemically is really important. Understanding the cost impacts is really important. And so I'm just thinking, and maybe this is not the right way to think about it, is that this is a bridge time where we have to figure out if such a decision came to us, what is the best way to go about it? But think of it as a temporary way of going about it because, and what I like is a real decision, like the buck stops somewhere. And for the moment, until we really figure out the strategic plan and who has the best set of eyes on that, it's Agency of Human Services. So everyone's involved in looking at it. But somebody at the end of this interim period says, it's a good idea, or no, I'm looking at the statewide healthcare plan and it's going to be a bad idea for the system. So I don't know if that's where I get stuck.
You honed right in on the mistake we made last year was the once established. But we can change that language. We can change anything we want. And we have to remember there's the statewide strategic delivery plan, which has not been established yet. There is current hospital treatment plans, which is ongoing. There's also the existing community health needs assessment, which is done every 3 years, 5 years. What is 3 years? And what was it? Was it HRAP? Health
Resource allocation plan.
Yeah, which has been.
No, that's dead. I mean, not dead, but
Well,
it's dormant. Should we say dormant?
Well, no, it's still in existence and it's every 5 years or something.
Pretty old.
Okay. Wendy.
Which leads me into what my issue is with this, is that there's so many balls in the air and we're just keep adding new things to it. And my issue with this bill right now is that I think that hospitals are playing with us now. I don't think that we need to keep adding new regulations and everything. I think I think if they go to the public and talk about it, they're gonna do it anyways. I don't think they're gonna do anything untoward at this moment right now in time. And I think we're doing a lot of things to put things in place. And I think if we take these 5 things and we just do a process of elimination right now, that we come to I don't like to do nothing. I do like that we do have them go out for a public hearing. I think being transparent is very important. And then I think if we go into the Green Mountain Care Board or AHS, if we eliminate one of those, and it sounds like most people here are leaning more towards AHS to be the oversight person. Because I think Green Mountain Care Board is getting kind of a bad rap out there, and I don't want to give them one more thing to be an oversight at this point right now. And that's my opinion. I just don't, I, from what I hear, I love Green Mountain Care. And then you have to ask if you want it to be binding or non-binding, and whether you want to throw money at somebody who wants to close something. I don't think that's the answer. To me, I think this is unnecessary right now. I think just being transparent is what we need to do. And then we're doing enough. Like, I just don't think that we need to keep adding things.
So that's 3. So that's 3.
No, I think 2 is mine.
That's number 3, which is just keep the public process and then remove the
Existing statute around service reduction.
interaction between
Interaction,
Yes.
yeah. Okay, so you're number 3.
Yes.
Great. Alan, did you have another?
If you say so. I like number 4, and I do believe AHS should be responsible. That's the agency. If they are the ones responsible, they will be working closely with Green Mountain Care Board anyway. So it's almost both. But yeah, seriously though, if agency resource makes a decision, and it is money wise, budget wise, it's got to go through the Green Mountain Care Board, right? So
Yes, if
they would have to work
If the
together.
reduction affects the budget.
Yeah, so they would have to work together, so. What's the
Well,
definition?
so I think you should hear from other people on retention stuff, but I'm not sure the board has the same kinds of levers for retention money that they do for addressing budgets through to address reductions.
What's the definition of the AHS? What's their job?
Well, an agency, we have to look up that definition. And human,
I mean,
that's debatable. And what is a service?
Oh, my God.
What is a service?
They have a mission though. I mean, they have presented.
I'm just
they're
curious.
established in statute, so they are,
Yeah.
Leslie, did you have something else you wanted to? So I see that after this discussion, we have an absolutely clear path.
We did have a straw poll. I'd be curious.
I think we should just to advance us. a bit.
Yeah, just see where it's like a jury, right?
Yes, or
Poll the jury.
What are we coalescing around?
I don't know if I want to do a straw poll, only because, I mean, maybe this is selfish of me. I'm really honest here, like I change what number I want every 15 minutes when I think about something else.
That's at this moment, and then there'll be new moments.
I would like to see more information before I go straw poll.
Okay.
Okay,
More
well,
testimony.
well, we're gonna do a lot more testimony. In fact, I think we're gonna sort of start over with testimony. Spoiler alert for everybody else out there who's already testified, you're probably gonna have to testify. I don't think we had enough thought process or understanding or to ask the right questions. And I really feel like we need to sort of start from the beginning. Okay, how about I just get a general sense? Not necessarily straw poll, but let me get I'll lay out 2 options. One is sort of just kind of leave things as either it is in the bill now or leave the process as is, where there's not somebody making final decision, or make a process where somebody has to make a final decision.
So you're not choosing one of those options, but you're kind of deciding which path. Let me just say, whatever we do, it's gonna include a public process. Can we all agree that there should be a public process?
Yes.
Notice of reduction, hospitals have to actually let the community know and go through getting some feedback. They can listen to 4 hours of people talking about that. So we've got an option of essentially go through a public process, but ultimately it's up to the hospital to decide what they're gonna do, or go through a public process and it's gonna be up to somebody else whether or not they're gonna open or close. Those are the two options that remain before us. And then once we determine where we're gonna go, then we will start tweaking that. Is that understood, Leslie, or are you confused by?
I'm not confused, but I'm struggling with your arbitrariness. I mean, I'm thinking about collaboration between the hospital and the agency and so I would feel more comfortable with that idea, not eliminating the hospital from the conversation, but having a three-way conversation somewhere in the world.
Well, that would probably, you would have to decide whether or not that collaborative process that you envision would mean that somebody had to be the ultimate arbiter, or the hospital just got to decide on its own, it's their own.
Well, if Rutland ultimately decided on their own, right? Yeah. But it's,
Well, no, actually, no, they didn't. Well,
I mean, they went through a conversation
they went through a conversation.
and then they made a decision. So I'm just saying, rather than just like, but I get your point, so.
Yeah, I'm not
Sorry to
saying,
be,
no, I'm not saying, I don't want to delve into the particulars of like how, I'm just a general philosophy of either somebody makes a decision or nobody makes the decision except for the hospital. Those are the two options.
okay.
Um,
So I'm kind of thinking like Leslie, I'm thinking they're already talking, they're already in such deep conversation. But meaning the regulators and the hospitals, that even if there's a final arbiter, it is in the context of that. Not just top down, but a real collaborative discussion.
Yeah.
So anyways, I just wanted to.
Okay. Okay, everyone who thinks that in the end, it has to be up to the hospital and nobody else gets to tell them what to do. I'm just trying to get a sense.
You said that one.
I'm taking the temperature of leave the hospitals alone or tell the hospitals what they can and cannot do after lots of collaboration and public process and all the other stuff goes
And
on.
now the voice came out,
And
okay.
that'll all come later, but either let the hospitals be or somebody make a final decision other than the hospital. All those in favor of let the hospitals be? 1, 2, 3, 4. Well,
It's a jury.
remember I said that like literally every 15 minutes I'm waffling, I'm like, what should I be number? Okay, all those in favor of finally having somebody be a final decision? Okay.
And I'd like to explain the vote.
Two hands, right? We went over the rules, clearly. I did not change my
No,
vote.
he's asking a question.
No, I am saying I prefer number 2 or number 1, I guess, in these
Okay.
1 and 2. But if someone says, AHS says, no, you can't close that service, we have to.
Yeah, like I said, we'll work out the
Okay.
particulars.
Then I'm,
In the end.
then I.
Oh, you wanna change your vote?
No, I'm on number 2.
But we did, number 2.
Well, I wait, know which hand you wanted to put down.
That's a valid point. I'm putting down my hand for the second option
Okay,
of letting somebody else make the decision.
okay,
Participating.
okay, so somebody has to make the final decision again, hands. 1, 2, 3, 4, 5. 5, 4. Can we work together take lots more testimony. And as a committee, come up with a process that everyone feels ultimately good with in the end, but that somebody gets to make a decision in the end.
We'll have to.
Is that,
That's,
can we do that?
I believe so.
I think we can do it.
Can I make
Okay.
a suggestion?
Yes.
That we still have testimony that not everyone in this room has seen from the care board and from AHS on
Yes.
who should hold the decision.
Yeah.
And it's worth reviewing.
I have
Yeah.
reviewed,
Yeah, and we'll have them in again.
but yes.
Yeah.
So is it in
We're gonna have them
writing
again.
or is it, did you watch it again?
I watched it again.
Okay.
Well, I actually watched the first time, but
We're gonna have them in again. And now that they all know what they're dealing with, they can. You're up for it. All right. Let's finish and take a long break before lunch. And allow me to work on Topper's business report. And we obviously will not be back after 4 today.
I gotta drag it out bingo.
And again, as of right now, we,
On a survey, 1, 2, 3.
as of right now, we have no committee tomorrow, but that may change depending on the floor. And if we do, it'll just be on 142.
I foresee receiving a lot of emails again about S64. Where are we on that? Are we gonna discuss it as a committee next week?
Yes, we're gonna take more testimony on S64 next week. Oh. I'm gonna make this public. I have had discussions with, just because I don't want there to be any lingering hanging out there. I've had discussions with all committee members individually. And I really feel like we got the sense with S164, which is the biomarker. 154. The biomarker bill that, you know, while, you know, these are really important things. Just with the things that were going on right now, particularly with defrayal and cost of care, that we would basically be spending $10,000 to get a report back that would tell us it's gonna cost money and we might not even have a defrayal, which would mean the state would be picking up that. And that doesn't seem like a good use of $10,000 to me. And I know it's a state budget and $10,000 doesn't seem like a lot, but that's a lot. That's a lot. And we shouldn't be frivolously spending money just because we want to put something off and have a report back. And I've talked to all the committee members, and I think that was, I believe, the general sense of everybody was we should not move forward. So we are not going to be moving forward on S154. Yeah. Going to be on our wall.
Yep.